So hello everybody, I'm so excited to be here to talk about pigmentary disorders with a focus on melasma. My name is Cynthia Golomb. I am triple board certified in dermatology, dermatopathology, and Mohs surgery.
I'm Dr. Mahtab Forouzandeh, or Dr. Zand, and I'm a board-certified dermatologist here at Skin Associates, and I have the honor of working with Dr. Golomb.
We wanted to focus on melasma because it's very, very common, affecting at least 1% of the population. Here in South Florida, it's probably 40%, and in areas of high UV exposure. So the first thing we want to bring out is what are the triggers? What types of light trigger melasma?
Absolutely. So melasma is a chronic hyperpigmentation disorder, and it's really important that patients understand there is a chronicity involved, and this is going to be a journey when they come to see us in a dermatology clinic. As far as triggers go, there's a hereditary component. 50% of people who have melasma have a family member who also has melasma. There is an inflammatory component. There is a heat component, an ultraviolet radiation component, including visible light. And then there is hormonal influences as well. And we're learning more and more about melasma triggers every day, and it's an extremely exciting area in dermatology just because there are so many new treatments and discoveries being made.
So the first thing I want to talk about is that a lot of my patients today, they're coming in and they put their picture on ChatGPT and they're telling me how to treat them. Mm-hmm. So I think the diagnosis of the pigmentary disorder is the most important thing. So if you get the diagnosis and then you put it in on your Google search, you can get some treatment options, but you have to have the right diagnosis. So when somebody comes in with pigmentary disorders and we're thinking of things like, could it be drug? Could it be melasma? Could it be hyperpigmentation from excess insulin or hyperglycemia or just pigmentary lines of demarcation? Right. So I like to say, what are the features of melasma?
So as far as recognizing melasma, I like to look for those symmetric patches on the cheeks, tends to spare the eyelids, and then has a very central facial distribution. A lot of times we have to kind of figure out, is it melasma, or like you mentioned, post-inflammatory hyperpigmentation, is it melasma or lichen planus pigmentosa, which tends to be more on the lateral parts of the face. And then there are other acquired dermal macular hyperpigmentosis type syndromes that we would have to differentiate melasma from.
Right.
So once we get that melasma diagnosis, we know that we're on the right track, and then we can actually get the patient the result they want. But the number one thing with patients in understanding the treatments for melasma, it's not just one cure, there's not one treatment, it's a journey that we have to go on with patients, right?
And that is the true thing. With melasma, it's a condition. It is a genetically driven photosensitive condition. There is no cure. Photoprotection is the main thing that we have to do. And there was even a study, sunscreen use 3 times a day alone without anything else can decrease melasma by 26%.
Wow. And we hear a lot about using tinted sunscreens now, right, Dr. Golomb?
Right. So we know ultraviolet light, UVA, UVB, cause the cells in the skin to stimulate a hormone called melanocyte-stimulating hormone, right? And that causes the melanocytes in the skin to secrete more pigment. Mm-hmm. So melasma is a disease not of more of these cells, but more pigment, right? And then ultraviolet light also causes decreased collagen in the dermis. So that collagen in the dermis becomes weaker, those cells become really big and pendulous, and they hang in the dermis, right? And then all that pigment drops out there, so you have all that pigment. And we know that visible light plays a role too, especially in patients with darker skin types or brown skin. And that is more of like a post-inflammatory type change, right?
Right, and something I like to really go into as far as patients using those tinted sunscreens in order to block both the UV radiation and visible light is a lot of times, including myself, I see that when patients are using a tinted sunscreen, they're not using the adequate amount to get the right protection. So they may be using those iron oxides in that tinted sunscreen to block the visible light, but are they applying enough to get that UV radiation protection that we're looking for? So typically I tell patients, go ahead and use your regular sunscreen, your regular physical block that's non-tinted, get your 2 fingers lengths worth, and apply that, and then follow that up with a tinted sunscreen if you'd like to, or if you wear a foundation or any sort of cosmeceutical that's pigmented, there's actually enough iron oxides in those types of things that will give you the protection from visible light that you're looking for.
Exactly. I agree with you. And you even talked to me about that people need to use a regular sunscreen and the tinted on top. They're not putting enough, right?
Yeah.
And then sometimes there's one product that we have here in the office, and it's like a little stick.
Love the
So I
sticks.
say 3 times a day, right? And you're not going to have all those bottles in your purse. You could have something like this or a compact,
Right.
and you just have it handy, and you could do your sunscreen stick.
Exactly.
Right?
Yeah, and I love
During
the
the day.
compacts that you just mentioned too, the powdered sunscreens.
Yes.
Those are awesome.
Those are great. So
Yeah.
that's something you need to have in your armamentarium. Okay, let's talk a little bit about, the blue light, because during COVID it was kind of funny because everybody was so worried about the computer screens and the iPads and the iPhones, right? And everybody was buying screens and special glasses. Well, we know maybe that plays a role in photoaging, but it certainly doesn't cause melasma. Because all these people in the call centers would have melasma, and that's
Right.
not the case.
Right. And then another trigger that we see with melasma, one of the biggest triggers, hormonal. So this is more prevalent than ever because there are a lot of people there on birth controls, and there's a lot of exogenous estrogen being given for part of HRT therapy, which is great. But we are seeing an uptick in melasma. Another thing I've been noticing is the uptick of using peptides. People are loving the peptides, and one of the peptides people are using is something called melanotan, which is an MSH analog. And so people are coming in, I don't know what's going on, I have all these new pigmented spots, my melasma's out of control, and those are things to keep in mind.
We do have to get a very good history. And another popular thing is the estrogen creams. Everybody wants estrogen cream today.
Yeah.
And the funny thing is the estrogen cream has never been compared to Retin-A
Right.
or tretinoin.
Right.
So we know for sure a fact that tretinoin builds collagen. We don't know a lot about these estrogen creams on the face, but we know for sure they can induce melasma.
Yeah, absolutely. And of course, it's always figuring out risks versus benefits. Obviously, hormone replacement therapy is very important for a large population. So sometimes, it's worth that increased melasma risk depending on the patient. So that's why it's really great to get a personalized approach when dealing with these things. And then pregnancy, obviously, melasma, another term for it is the mask of pregnancy. And a lot of it will resolve once the baby is born, but some of it sticks around. So what do you like to do for those patients?
So glycolic acids are very safe in pregnancy. Glycolic acids, lactic acid, mandelic acid, azelaic acid. So that's typically what I recommend, and of course, photoprotection. Then after the baby's born and after they're finished breastfeeding, we can go after it stronger. And sometimes there are some ladies who will do a little laser without topical numbing. I have patients that will do something like Clear and Brilliant or BBL during pregnancy, or even microneedling if they can do it without some topical numbing cream.
And then some of the other things you like to do for melasma. Oh, I guess we haven't even started with the beautiful triple therapy cream that we love to use.
Right.
That's been basically the gold standard for melasma for a very long time and is backed by so many different clinical trials. And that triple therapy includes a retinoid, a hydroquinone, and a weak topical steroid. And the reason why this triple therapy works so well is because the hydroquinone is a tyrosinase inhibitor, so it calms down the pigment-producing cells. And then the tretinoin will help cellular turnover, so it will help kind of flush out those pigmented cells. And then the hydrocortisone is great because those other two ingredients can be a little bit inflammatory, and we know that inflammation is the enemy of melasma as well. So that hydrocortisone or fluocinolone or whatever is compounded in that triple therapy will help calm down the irritation that may be triggered by those other two ingredients. And it's just a beautiful combination that we love to use, and we actually like to start patients on that before we really go further.
Right, that is correct. And that is in a non-pregnant female.
Right.
I do want to just mention a little bit because there's a lot of hesitancy to use topical steroids today. Patients are always coming in, they don't want to use topical steroids because they say it thins the skin. But there are articles published in some of our derm surgery journals and some of our dermatology journals. And there was one published in 2010 that says these low potency hydrocortisones or fluocinolone does not cause epidermal atrophy, and they are very safe to use. Now, high-potency steroids can, and that's one of the problems with people treating themselves and having unsupervised treatment, right? Because they're using high-potency topical steroids that can thin the skin. It could cause hair growth, right? Cause increased blood vessels as well. So it's very important to have supervised treatment of melasma and pigmentary disorders.
Another favorite medication I like to have in my toolbox when it comes to treating melasma is oral tranexamic acid. And I think in the right patient, this medication is absolutely amazing.
Tell us a little bit more about how it works and who you use it in and how you use it.
So technically, oral tranexamic acid was used for increased menstrual bleeding, and the mechanism of action is a little bit unknown in melasma, but we do know that it's an antifibrinolytic. So there is that hypothetical risk of increased clotting. And in a lot of the randomized clinical trials, there really wasn't a significant risk of this clotting. There was one patient that had a venous thrombosis, but they did have an underlying factor V Leiden issue. So in the right patient, it's an incredibly safe medication, and I really like to reserve it for my refractory cases or during that 1 month period that we take a break from the hydroquinone. I might put a patient on that maybe 2 weeks prior to that 1 month break and 2 weeks after, just to hold them over. So it's a really amazing medication. Again, we're not sure exactly how it works in melasma, something with the inflammatory pathway, but it's been a game changer for me.
Yeah,
as far as
I agree
medications.
with you. And I think that that's something that is also starting to be overused. Everybody's prescribing it, and I think that there could be some problems if you don't get an adequate medical history.
Absolutely.
Did you know it's over the counter in the UK and in Sweden?
Way. I had no idea.
It's over the counter. How about that?
Wow. Would you like to go over some of those risk factors that we look for with patients?
Of course, people with clotting disorders, there's something called protein C and protein S deficiency, as well as what you mentioned, the risk of the factor V Leiden gene that some people have and have a risk of DVT. Of course, you wouldn't use it in pregnancy as well.
And then what's your thought process on using it on patients that are using oral contraceptives or exogenous estrogen therapies, or if they're smokers?
Definitely don't use it in smokers, and I don't use it on people who are taking hormones of any kind. I agree. That's something you have to ask.
Yeah, absolutely. And then some of your favorite in-office procedures. I know you mentioned a few for pregnant patients. What are your go-tos for just the regular melasma patient?
That's a great question, because we know that melasma is not just about pigment, right? There are other things going on. Inflammation, there's increased blood vessels. So one of my favorite lasers, everybody knows this because I'm always doing little Instagrams on the BBL. So the BBL and the Moxie, which is a 1927 laser, are my favorite lasers for melasma. And although sometimes we don't go right away to procedures, we do topical therapy first. I do like procedures as a jump start. I find that it does help a lot, especially with topicals. I never use procedures alone. It's always procedures and topicals. And I have to say, in my hands, the BBL and Moxie are my favorite. And I'll do maybe 2 treatments a month apart, and as well as incorporate the topical regimen.
For me, my go-to is basically a series of chemical peels after I get the melasma under control with the topical therapies at home. So I really love like a low percentage TCA peel. Sometimes I'll start with a 10% and maybe move to 20 to 30. Sometimes I'll combine that with a Jesner peel. But I find that the peels work really beautifully as well. And then laser-wise, I really like the Pico. And then, and every now and then I'll do the Moxie or the Laser Genesis and get that inflammatory component under control as well. So it's fun to see how every practitioner kind of approaches melasma differently, but there's a secret sauce that will work for a single patient that may not work for another patient. So it's really nice to try to figure out what works for those patients.
One of my favorite treatments of melasma, and it's been proven to be an excellent treatment, is a procedure called microneedling, but it has to be with topicals. And everybody's talking about the exosomes, right? So here in the office, we have a particular exosome which has a topical tranexamic acid. And you love that one, right?
I love that one. It's an anti-age exosome, and it's basically a very great adjunct therapy to Fraxel or any sort of microneedling. really any laser, it calms down the skin, decreases inflammation, reduces healing time, and that topical tranexamic acid that's inside the solution really helps brighten up the skin.
Right. And that also has exosomes, right?
Yes, absolutely.
Yes, so that is a very, very exciting product that we have here at Skin Associates, where we do microneedling with the skin pen and the anti-age with tranexamic acid. And I have seen patients doing well just after 2 treatments. And a lot of times with melasma, it can be very heartbreaking because you could come in on a Friday and look great, go out in the sun or, walking the dog too long, and you come back Monday and it's flared up.
It only takes one bad weekend in the sun.
That's all it takes, right?
What are some of your ingredients that you like to have patients use in that 1 month period where you have them take a break from the hydroquinone?
Right. We were talking about rotating therapy, and everybody has their different algorithm, right? Because we don't want to continue hydroquinone every day throughout the year, right?
And just to go over some of the reasons why we don't do that, there is something called exogenous ochronosis. So it's very rare, and it happens in patients that are using it without any breaks for a series of years, 3 to 4 years. And it doesn't matter what percentage the hydroquinone is. It can happen from a 2% all the way to an 8%. But basically, it's out of an abundance of caution that we like to take those hydroquinone breaks every 3 months for 1 month.
And hydroquinone is actually very safe. There was a Pfeiffer study. It was in the late 90s, actually, and they looked at factory workers who are exposed to hydroquinone. Usually it's in the photographic industry, right? They looked at those factory workers and they compared them to controls who had no exposure to hydroquinone. And you know what? The people who didn't have exposure to hydroquinone had more risk of cancer, had more cancers than those that were exposed. So hydroquinone does not cause cancer.
2 really popular ingredients to control melasma when you're not using hydroquinone: cysteamine and thiamidol.
Yes. We have cysteamine here.
There we go.
We have this Sente cysteamine.
And this is great. I've used it. It's a little bit smelly, but cysteamine is great for sensitive skin. So if you have melasma and you tend to have sensitive skin, or you're not able to tolerate hydroquinone, because hydroquinone can be irritating, this is an excellent alternative that actually works. Sometimes I'll have them use this and alternate with azelaic acid gel, which is also fine in sensitive skin.
It's a non-hydroquinone. So that's what we were talking about too. We kind of pulse our regimen. We don't keep a person on the same thing. So usually I'll do 3 months with hydroquinone every day. Then I'll do 3 months with weekends only or twice a week. And then I'll do 3 months off where I use a product like cysteamine, or I think this SkinCeutical product has azelaic acid in it, and I think it has arbutin. It has arbutin and azelaic acid. So then we'll have them use like a brightening cream for 3 months, and maybe an oral tranexamic acid as well. So we do kind of pulse the regimen, but it is a treatment that you need to revisit. You have to come back and see your dermatologist and talk about it. It's something that you just don't give the regimen for a year. You have to see your patients every 3 or 4 months.
Right. It's a journey.
Right? It's a journey.
So melasma is a chronic condition, and that's why it's so important to get a consultation with a board-certified dermatologist so that patients can have the right understanding of what they're dealing with. It is not a one-and-done type of situation. Even though it may have came out of nowhere in a period in your life, that doesn't mean it's going to go away and never come back once you see a dermatologist or once you start a treatment plan. It is an ongoing issue, but we can definitely get it under control. There is hope. We just have to personalize the plan that fits your needs, your skin sensitivities, and fits your lifestyle.
So that's actually a good question. Laser treatments cure. Nothing is going to cure melasma permanently. It is a genetically driven photosensitive disorder, right? The only thing that might cure it in the future is if we can locate the exact genes causing it and cut them out of the DNA.
Right.
That might cure it. And that's on the horizon, although those are very expensive treatments. So it is genetically driven. The triggers like the ultraviolet light, pollution, they stimulate the cells to produce more pigment, and that's just not going to go away.
Right.
So we try to target those causes.
Absolutely. 10% of melasma patients are men, and I treat lots of men with melasma, so they can absolutely get melasma, and the treatment plans are very similar to the treatment plans we have for females. Sun protection, hats, SPF, reapplying.
I have to agree with that. Sun protection is the most important thing. It has to be overstressed to your patients. And everyone says to me, oh, I use sunscreen. But again, it's not enough and it's not frequent enough. There's a lot of new ingredients coming out, right? So, everyone's talking about the gut microbiome, and there is some evidence that people with melasma may have a different colonized bacteria in their gut. So that's something that's being looked at in the future. There's a new ingredient called Melasma that people are talking about. So some of these new over-the-counter creams can actually be quite effective. New things are coming out. What else is new? We talked about the pollution playing a role. Something we didn't talk about too much is heat. I used to think about it a lot, and I would tell people even cooking in the kitchen and heat could cause melasma. So I used to tell my patients, have a cool towel and just cool your skin off. I don't hear a lot of people talking about that today, but I still recommend it because heat is like a stressor that can trigger inflammation.
That is such a good point, and especially in South Florida and just with the active community that we have here in Miami, so many people are doing hot Pilates, hot yoga, they're going to saunas. It's so important to ask about lifestyle and those types of things.
Right, saunas, that's a good point. I think you shouldn't use estrogen creams. I think you need to be careful about taking hormones. You also definitely sun avoidance. It's like iron oxide is the important ingredient in the tinted sunscreens, right?
Yeah, that we have in all our pharmacies.
Right, we have that. I have one here, I think that we sell. Do I have a tinted? Yes. No, actually I don't. I have a sunscreen that we have here at Skin Associates, and it's interesting because a lot of the sunscreens now, they have also brightening agents. So one that we have here, it has a vitamin C with the sunscreen as well.
Well, thank you for joining us on this episode of Skin Deep. We hope to see you again soon.